Okay, thank you, colleagues. Welcome to our webinar this morning on behalf of the Ministry of Health and Medical Services, and also on behalf of the Incident Management Team for the COVID-19 response. This is a training that we've been looking forward to. As you know, we have different situations in the divisions, in the Central, Western, and Eastern Division. But before that, I just want to go on some of the housekeeping issues. And please mute your mic so that we do not disrupt the facilitators. You're most welcome to use the chat function to ask your questions. And please raise your hand. We have, 1.5 hours, but we will try and as much as possible not disrupt the facilitators so that we have a clear flow of the presentation and discussions at the end. So following housekeeping, I think that's basically the housekeeping. Everyone's familiar with the use of Zoom. Mute if you're not speaking, raise your hand if you need to ask a question using audio. Otherwise, use the chat function. I have here support from the Data Management Unit, Ms. Vara Nisese Smith, who is our Senior Stats Officer. She will be also identifying the chat function, while we also have our IT persons providing support. I acknowledge support of Liz from IMT, who is from the DFAT facility, who is also included us as part of the webinar series of IMT. Acknowledge Dr. Alepate and also our clinicians, senior clinicians that are joining in, Dr. Luisa and Dr. Ravi. So without further ado, we'll go straight into the next part of our agenda, unless anyone has any specific questions. Okay, no questions. So at the start, we would like to have a discussion, and I'd like to invite Dr. Lisa, Dr. Ravi on the specific issues and the processes that they've undertaken in the Central Division. As you know, Central Division is in the mitigation phase and has a different strategic focus. So thank you, Dr. Ravi and Dr. Luisa.
Thank you, Dr. Eric. I'll now hand over to Dr. Ravi, who's in charge of our COVID response things.
Thank you, Dr. Luisa and Dr. Eric, and thank you to our counterparts from Australia. This is a very important training we're having. So just to roll off the discussions, what we are doing at the moment. So in CWM, every death that we were having was actually discussed in a forum with multiple specialties. So we had a physician, a nephrologist, an ICU doctor, and a surgeon, or whichever particular specialty the death was occurring in. We had a panel discussion. We went through the case. It was seen as an auditing process, and then we came up with a classification. The questions we needed to answer first was, is this a COVID death? Is this a non-COVID death? Because initially we had a cluster of patients with very severe illnesses acquiring COVID within the hospital. So we came up with this process to have a more of a auditing to improve our function and to get a clearer picture of what actually happened to the patient. So that's one arm. And as we move on to the mitigation phase, what has happened is the resources, human resources have been stretched. There's a lot of consultants on the ground. So those Zoom sessions or those panel discussions are not happening, but these discussions are happening on the ground and as we see the patient, and which is quite dynamic process. And that's for inpatients. there is also a category which is, I don't have the specific numbers with me, but probably there's a large chunk of patients who are dying before arrival into hospital and dying at home. And for that has been a bit of a challenge for us. And we also had similar processes where we discussed with multiple doctors before we had a classification of death. And in special circumstances, in one particular circumstance, we had a panel where we had a forensic pathologist, a hospital pathologist, me, the medical superintendent, and an ED doctor sit and discuss a case in detail before we came up with a classification. So those are some processes that we've highlighted to have a more clearer and transparent way of putting things on paper. And the forensic pathologists have also come up with a SOP, which is a couple of days old, where wherever there is a dead on arrival, the medical officer who sees the particular, who attends to it, becomes the primary responder. So they are in charge of collecting a history and for documentation. And then there is a secondary responder. In most cases, it's the forensic pathologist. And then the tertiary responder, which is a specialist, either me, ED doctor, or someone. So those are the things we have in place because sometimes it becomes very difficult to classify. And the challenge we are having, and I think after this training, is getting a very detailed history from the first responder for DBAs. And that history is quite crucial because it, in most cases, we cannot do a postmortem, and that history plays a big role. In the hospital, it's quite easy. We have a lot of specialties, and the patient has been seen, so we know the clinical continuum as it happens. So that's all from my side, Dr. Eric. That's just to start off what we're facing and what we've done and how we playing ourselves just to make sure that the process of classifying death is as important as our patient care. Thank you.
So thank you, Dr. Ravi. I also want to raise the issues raised by Dr. Nashika, who's looking after the mortality data. Now, it's a chronic issue, and we've tried to address this. It's been addressed by the major divisional hospitals with ensuring the identity of the person that has died. So in the process in CWM, the normal process is that you're required to provide a birth certificate of the person who's collecting and the deceased to certify that the person is as is. But according to Nashika, they don't receive some of the names and don't match. What they're attempting to do is match the deceased names, the correct names, with laboratory results to gain more data on whether they've been vaccinated. For example, matching it with laboratory data, matching it with vaccination data. So that's one of the issues that has been raised by Dr. Nashika. And just to add that we have the Tamone established for the laboratory digital support with Dr. Alicia and Dr. Rachel for the vaccine data and the lab data to be matched in terms of identifying persons. And Digital Fiji also is giving out unique ID numbers, and we should sort that out in the near future. But in the meantime, I think the message from Dr. Nashika is that we need the doctors to ensure that the persons that are the identification of the person on the death certificate has to be a verifiable, either a BRN identity or some other identity that that has the correct names and details. So I think that is the message from our IMT team. Dr. Rachel, any other clinicians want to add on the issues that I have this morning? It basically means, we start off the issues so that as our facilitators, international facilitators go through the presentation, they can address some of these issues. Is there any other clinical issue that anyone wants to present before I present the data from IMT that I've just received? Okay, I don't see any hands up, so I will just quickly go through the slide that is now currently presented to the senior managers on our latest data before we go on to the international facilitators. Can I share? Ashanu, can you just share? Can you share my screen?
So you have to share it from your end.
Have you got it?
Yes.
Okay, colleagues, so this is the brief for today from IMT. Thank you, Dr. Kulai and Dr. Nashika for this update. And this is the situation as of 24th July today. In terms of the daily deaths, 7-day rolling average of 10, and 82%, a high proportion of the deaths were unvaccinated. At least 18% had one vaccination with one dose. So in essence, we don't have any deaths that were fully vaccinated. So you see the age distribution. You can see that a significant number are above the age of 50 from our mortality. And what is really of great concern to the ministry is the amount of deaths that we are having at the homes. And as everyone understands, we've had this issue with health-seeking behavior. A lot of people find, even those in the rural communities, usually, and everyone has this experience, they come quite severe also. And it's unfortunate for our clinicians that they can't do much when it's come quite bad. And so we have a lot of these dead on arrival cases. And in terms of our certifying, it's also difficult because it requires, as what Dr. Ravi has mentioned, some discussions and some relooking at the data of the personnel, person who have deceased, to find some historical or some link to COVID-19. Some of the deceased, I think, are tested also. There's also another process. I think that's basically the data we have. I think it hasn't been updated. I know in yesterday's discussion, it hasn't really been updated in terms of our pediatric deaths. Thank you. Anyone wants to raise any further issues that we can share with our international facilitators? If not, we can further discuss this at the end of our training. So let me at this juncture invite our international facilitators, and at the same moment acknowledge our SPC colleagues who have always, in WHO, have always supported us in this training. From last year, we had it in early March, and this year, for training for this year on MCDC. Thank you, Sue and Lauren. Can you please introduce yourself, and then we can start on our training. Thank you.
Thank you very much, Dr. Eric. I'm Sue and I'm starting. So just I hope that you can see my screen now. Okay, so today we'll be talking about, as we all know, certification and coding of COVID-19. And thank you very much for that update about what's happening in Fiji. That was really useful information. So who am I? My name's Sue Walker. I work at the Queensland University of Technology in Brisbane. I actually have two of your former staff members from the Ministry of Health studying with me at the moment. I coordinate the Bachelor of Health Information Management. So some of the issues that you've been describing about being able to uniquely identify patients is something that I'm really interested in. So I'd like to continue that discussion later if we have time. So we all know about COVID-19. It's an infectious disease. It's a form of coronavirus. There are a number of other different types of coronavirus that have been identified recently, including Middle Eastern respiratory syndrome and severe acute respiratory syndrome. But this particular type of coronavirus was first identified, as we all know, in China in December 2019, and hasn't the world changed since then? So the information that I'm presenting comes from the World Health Organization. So a lot of the things that I'll be talking about are the way that WHO is recommending that we capture information about COVID-19 and the way that it is coded. So we'll talk some more about that. But basically, WHO has provided a global surveillance definition for what it considers COVID-19. So this is a death resulting from a clinically compatible illness in a probable or confirmed COVID-19 case, unless there's a clear alternative cause of death that is or cannot be related to COVID-19, such as a motor vehicle accident or something like that. And importantly, there should be no complete recovery from COVID-19 between the illness COVID-19 and the death occurring. So what WHO is recommending is that COVID-19 should be recorded on the medical certificate of cause of death for all people that die where the disease is caused. I think somebody hasn't got themselves on mute. If they wouldn't mind putting everybody on mute, please. So start again. COVID-19 should be recorded on the medical certificate of cause of death for all people who die where the disease is caused by, or is assumed to have been caused by, or is believed to have contributed to the death occurring. And we ask that the official COVID-19 terminology is used where COVID-19 is being certified. Don't just write coronavirus, because as we know, there are a number of different types of coronavirus. And for the people who are trying to manage the data and reading the death certificates, if they just see coronavirus, they're then uncertain about whether we're talking about COVID-19 or some other form of coronavirus. So the terminology COVID-19 is preferred. So these are the case definitions for global surveillance that have been produced by the WHO. So they say there is a definition of a laboratory confirmed case. So this is a person with laboratory confirmation of infection with COVID-19 virus, irrespective of whether or not they are displaying or demonstrating any signs and symptoms. So if the lab says it's COVID-19, it's considered a laboratory confirmed case. Then we have clinical diagnoses or probable cases. And these are ones where the case is suspected to be COVID-19, but either there is an inconclusive laboratory test. Could everybody put themselves on mute, please? So either the laboratory test is inconclusive, or there's no possibility of doing a laboratory test. But from a clinical perspective, the treating physician has determined that the patient is actually suffering from COVID-19. So these are clinically diagnosed or probable cases. And then we have 3 different types of cases that are considered to be suspected COVID-19. The first is where the patient has an acute respiratory illness, and there's some examples of what you would consider an acute respiratory illness on the screen. So the patient has a fever and at least one of the respiratory symptoms, such as cough, shortness of breath. As well as that, they also have no other etiology that explains why they are suffering from those symptoms. And they have a history of travel to or residence in an area that has reported local transmission of COVID-19 during the previous 14 days. So that's the first suspected case. The second is the patient again has an acute respiratory illness and is a contact of somebody who has a confirmed or probable case of COVID-19. And that contact has been within the 14 days prior to the onset of this patient's symptoms. And then the third definition for a suspected case is again somebody with severe acute respiratory infection and who requires hospitalisation, and there is no other reason that explains the current symptoms of the patient. So each of those three are considered suspected cases. We also, of course, have some patients who we suspect have COVID-19, but when they have laboratory testing, they find that COVID-19 is not present. And if laboratory testing is not possible, after examination, the clinician also may decide that it is not actually COVID-19 that is causing their symptoms. So these are what we call ruled out COVID-19. So in terms of the international capture of mortality data about COVID-19, deaths due to COVID-19 are the ones that are counted when we're capturing our mortality data and reporting it internationally. Deaths due to COVID are different to deaths that are related to COVID, or we call them either COVID-19 related or COVID-19 associated deaths. And these are ones where there's an accidental or incidental cause of death, or even a natural cause of death, where COVID-19 might be present, but it hasn't been identified as the underlying cause of death, according to the WHO coding guidelines for capture of COVID information. And I'll talk about those some more in a moment. So what the WHO has done is develop a series of new codes, and I'm going to go through each of these. Now, I know most of you are clinicians, and it won't be your responsibility to actually assign the codes, but I think it's important for you to understand the options that the coders in the Ministry of Health, who will be coding your mortality data, you see what sort of options they have for the codes to be assigned. Now, at the moment in Fiji, you are using the 10th edition of the International Classification of Diseases, as is nearly every other country in the world. But there is a new edition of the classification, which we call ICD-11, which is the 11th revision, which will start to be used from about 2022, middle of 2022 onwards. But at the moment, ICD-10 is what is being used in Fiji. So the codes I'm about to present are the ICD-10 codes, and they're the ones that we use in Australia too. So the codes have gone into a chapter in the ICD-10 that's called Chapter 22, Codes for Special Purposes. And they're in a big block of codes which are nominated as for the provisional assignment of new diseases where the etiology of the disease is uncertain, or where there's an emergency and we need to quickly be able to capture information about a particular condition. And COVID-19 is one of those examples. So in this big block of codes that range from code U00 to U49, we have a group which is for the codes where there's some uncertainty because we don't really know too much about the disease and we don't know where else in the classification it fits. Most of the classification is based on body system diseases. And at the time that these particular conditions have been identified, there was uncertainty about exactly where they belonged. And SARS is an example. The codes for COVID-19 are the emergency use codes. So what the WHO has done is identify a series of codes which had no description for a while. They were just nominated as placeholders so that if some new and important disease was identified, then those placeholders could be used to capture information. And at the moment, we've got two different conditions that are being placed in these emergency use codes. One is for vaping related disorders and one is for COVID-19. So what I'll talk about now is the COVID-19 codes. So just in case you're interested in actually seeing what the classification looks like, you can, I'll give you the website in a moment, but there is an online browser version of the International Classification of Diseases, which has all of these codes in it. So if you are interested in going and looking in more detail at the codes, I'll give you the link. You can actually go and have a look. So the link is on the screen now, and we are recording this, and I believe that the PowerPoints will be made available. So what I'll do now is just quickly take you through each of the different codes. So these are the codes that your Ministry of Health will have to choose from when they're coding COVID-19 deaths. And the hospitals where coding is done for hospitalizations, these codes can also be used. So the first of them is U07.1, which is COVID-19 not otherwise specified. NOS stands for not otherwise specified. And the regulations say use this code when COVID-19 has been confirmed by laboratory testing, irrespective of the severity of the patient's clinical signs or symptoms. And then there's an instruction, you can use an additional code, so a second or third or subsequent code, to identify the current manifestations of COVID-19 in that particular individual. Now, there are a number of exclusions. So what that means in coding terms is if you think you want to code a coronavirus infection, then unless it's COVID-19, it doesn't go into this U07.1 code. There's a different code for an unspecified coronavirus infection. Equally, if there's coronavirus that's been described as the cause of disease classified to other chapters, this is coronavirus not otherwise specified, not COVID-19. Again, there's another code. So there are some things where a coder might get to this U07.1 code and then realize that actually they're not in the right place because these exclusion notes will send them to a different code. The second of the COVID-19 codes is U07.2. So the description is COVID-19 virus not identified. And the information says use this code when COVID-19 is clinically diagnosed, but laboratory testing is either inconclusive or not available. And again, there's an instruction, if you know the manifestations in the patient, you can code those as well. Don't not use U07.2, but add to it to give more information about the patient's current manifestations. And again, there's a number of exclusions which say, if you've got these particular circumstances, don't use U07.2. So for example, if you've got COVID-19 with a confirmation by laboratory testing, don't use U07.2, use U07.1. So these are mainly instructions to coders to make sure that they're assigning the codes correctly. Then we have a series of other codes. So this particular one, U08.9, is for a personal history of COVID-19. So this one will never be your underlying cause of death. So it won't be reported as a COVID-19 death. But it's an optional code where if you know that a person has had COVID-19 in the past, and that has possibly influenced their health status, but they don't have the condition anymore, you could put something into part 2 of your medical certificate of cause of death to say, actually, this person had COVID-19 in the past. They don't now. So make sure it's quite clear that this is a history of COVID-19, not a current infection. And if you've made that quite clear, then the code U08.9 personal history of COVID-19 could be used. The WHO has developed the code U09.9 for post-COVID condition unspecified. At the moment, we are all internationally a little bit uncertain about what conditions patients who've had COVID-19 might be left with. So this is an optional code that countries can choose to use to say, well, this patient has had COVID-19 and now they've got this particular long-term effect, and maybe there's a link between the two, and we're a bit uncertain if there is. So this is basically a code to be used so that in the future, when we understand more about COVID-19 and we can do some analysis of COVID-19 data, we might be able to start understanding what conditions COVID-19 can leave in patients who are have currently recovered from COVID-19. So this code will never be used for somebody who has a current COVID-19 infection. We do know that some patients experience multi-system inflammatory syndrome, which is associated with their COVID-19 infection. So we have a specific code for that, U10.9. And this includes things like Kawasaki-like syndrome or multi-system inflammatory syndrome in children. So these ones are where that multi-system inflammatory syndrome is specifically associated with the COVID-19 infection. And the WHO was asked to produce a code to allow the capture of patients who are attending a health facility where they are attending for immunisation purposes. So these codes are never used for mortality capture. They are used for hospitalisation information, morbidity coding, just to be able to count the number of people who are attending the facility for immunisation. So they're never going to be used for international comparison. They're used for management of an individual country's health system. And finally, we are aware that some patients suffer from adverse effects as a result of their COVID-19 infection, their COVID-19 vaccination. So U12.9 has been developed as a code to identify that. It is considered the same as an external cause code. So just to explain what that means, if you've got somebody who's had a motor vehicle accident which has resulted in all sorts of different trauma, so they might have had a skull fracture or a liver laceration or exsanguination or something like that. When we code mortality coding, the underlying cause of death which we use for reporting purposes is that form of trauma. So it's the motor vehicle accident, it's the suicide, it's the fall, whatever the cause of the trauma was. But we also capture the types of trauma in the patient that have been caused by that external cause. So what this particular code has been developed to be used as an external cause code. So what we would hope that you would certify is the nature of the adverse effect that the person has suffered, plus tell us that you believe that it is due to the fact that they have had a vaccine. So we link both the nature of the adverse effect and the vaccine as its cause. And this U12.9 would be the cause code that we assign. Okay, so moving then on from codes to certification. So WHO has produced some guidance back in June 2020, and it hasn't been updated, for reporting of COVID deaths. So again, I've given you a link. If you'd like to go and read this in more detail, you can do so. What you can see on the screen now is the current version of the medical certificate of cause of death that's recommended by WHO. And this part here that I think you can see my arrow moving around, this part here is the medical certificate of cause of death section, which is exactly the same as what you have in Fiji on the death certificates that you use now. So it has two parts. It asks you to report a sequence of events leading to the death, and what you believe as the clinician is the underlying cause of death, reported on the lowest used line in that top section. So what WHO is saying is that COVID-19 should be documented for all certification of this cause of death. And please include detail if you know it. So if you know that this COVID-19 was laboratory confirmed, tell us that, because as you saw before, there are different codes for COVID-19 that's been laboratory confirmed and clinically diagnosed. You don't have to tell us a whole story, but enough information that somebody who is actually processing and coding this death certificate will be able to assign the correct code, because the codes are what we use for international reporting. So just to reiterate, both categories U07.1 and U07.2 are suitable for us to be able to report COVID-19 deaths. Some are identified by laboratory testing, some are clinically diagnosed, but both are considered COVID-19 deaths. We do recognise that in many countries and some areas within countries, we don't have laboratory confirmation, but we ask that you tell us whether or not the COVID-19 death that you're reporting is laboratory confirmed or clinically diagnosed. What WHO said is, for mortality purposes only, we will code anything that's reported as a COVID-19 death to U07.1, COVID-19 virus identified, unless it is stated as being probable or suspected. So we have a default to assume that it is a real COVID-19 case. So what the coders do once they are processing and coding the death certificates that are completed by clinical staff is that they assign codes for each reported cause of death, and then they assign what we call the underlying cause of death, which is the condition which started the chain of events which led to the person dying. And there are international rules in the International Classification of Diseases which standardise the way that underlying cause of death is reported. So what the rules tell us in terms of COVID-19 is that COVID-19 cannot be ever considered as due to any other condition. So COVID-19 is not a consequence of any other disease, at least in terms of reporting. And it will never also be linked with any other condition. So there are certain conditions that we can capture, which if there's more than one condition reported on the death certificate, there may be an instruction to either link two together, say these two conditions are obviously associated with each other, or there is a preference to assign the underlying cause of death as one or the other. But in terms of COVID-19, it stands alone. We will never link it in terms of the coding or modify its coding. So the way that the coding rules apply is very similar to the coding rules that we apply for deaths reported as due to influenza. Now, I'm not going to go into those rules in great detail. You don't need to know that. But if you are interested, again, I've given you a link and you can have a look and see what the instructions are. And just bear in mind, these instructions come from the World Health Organization. They are used by every country that uses the ICD-10, and they're designed to enable us to produce data that is comparable internationally. So we don't change the rules to suit a particular circumstance or a particular country. They are international rules which are designed to provide that comparable data. So here are just a few examples from WHO, and then I'm going to hand over to Lauren, who's going to give you some examples of COVID-19 deaths that we have seen in Australia, and I believe we've also got one from Fiji. So in this particular example, we have a patient whose immediate cause, which is the condition which was closest in time to them dying, was acute respiratory distress syndrome. They had that for 2 days. It was due to pneumonia. They had the pneumonia for 10 days, and that pneumonia was due to COVID-19 with a positive laboratory test. So in this case, our underlying cause of death is going to be that COVID-19. Now, on the screen also, I've given you some instruction about how that decision was made. Given that we don't have coders online, we have clinicians. I'm not going to go through that instruction, but just be aware that there is, in fact, a rule that says this is how we decide that in this case, COVID-19 is the underlying cause of death. And the coding rules align with what the clinician has documented. In this case, it's similar, but here we have a suspected COVID-19 death. So here the code will be U07.2. So the case has been explicitly stated as not being laboratory confirmed, but it's suspected and we can code it to a COVID-19 death. This one is not a COVID-19 death. So this patient had hypovolemic shock for a day. It was caused by the fact that they had an aortic dissection, and that aortic dissection was a result of a motor vehicle accident. And in part 2 of the certificate, you can see that COVID-19 has also been reported as a significant condition, but not in this chain of events, which actually was the result, which resulted in the patient dying. So in this case, the underlying cause of death was the motor vehicle accident, which caused the aortic dissection, which caused the hypovolemic shock. So here the underlying cause of death is actually the motor vehicle accident, regardless of the fact that the patient is said to have had COVID-19 as well. Here's another one where the COVID-19 reporting does not result in this being a COVID-19 death. So here we have a patient who has heart failure due to a myocardial infarction. They are said to have COVID-19 as well, which is a condition which contributed to the death, but was not in the chain of events that led to the death occurring. So in this case, the underlying cause of death is the myocardial infarction, which has caused the heart failure. So myocardial infarction is your underlying cause of death here. Just quickly, a little bit about morbidity coding. So I know we're focused more on mortality here, but I thought it was probably important for you to understand that there are some differences in the information that's captured and coded for admissions to hospital compared to what's on the death certificate. So when a patient is admitted to hospital, once they are separated from the hospital, separation means they're discharged or they die or they're transferred to another facility, somebody in the hospital will be coding what happened during that episode of care in the hospital situation. And every admission to hospital must have what we call a main condition. So this is the first thing that somebody coding at the hospital level will assign a code for. And the main condition is that condition diagnosed at the end of the episode of care, which is believed to have been primarily responsible for the patient's need for treatment or investigation. So diagnosed at the end of the episode of care means the patients come in, they've had their investigations, they've had their history taken, there has been some clinical decision making that has determined exactly what it was that caused the need for that admission. And that becomes what we call the main condition that is coded. And there might be more than one such condition. And then we have a more complicated decision to make in regard to what the greatest use of resources was. And whichever condition was responsible for those resources will become the main condition. And in many countries, We also capture information about any other diagnosis or problem that is dealt with while the patient's in hospital. So these might be conditions that already exist with the patient when they came into the hospital, but weren't the main condition, or they might be things that actually develop during the episode of healthcare. So we capture information about all sorts of diagnoses that are treated during an episode of hospital care. So there are a series of codes that we would use in a hospital situation. So for our laboratory confirmed cases, what I've given you on this particular slide is patients who have no symptoms, patients who have symptoms, and the codes to be used. So the patient has a positive test, regardless of whether or not they're showing any signs and symptoms, we will code to U07.1. If they have a positive test result, and or if COVID-19 is documented as a cause of death, we will code U07.1. If they have a positive test result and they have manifestations documented by the clinician during the hospitalisation, we'll code both, the COVID code and the respiratory symptoms that have been described. And there are some additional codes which some countries use and some don't. So this is a decision by the Ministry of Health in Fiji, whether or not these codes are to be used. For isolation, so patients who might come in and are isolated because they have COVID-19. And some patients use actually a code for the examination, the laboratory examination. Patients with suspected or probable COVID-19, again, here we have patients with acute respiratory illness where they have contact with or exposure to a case, and the codes that we would use. So where the patient has no etiology, no history of travel, but they have been in contact with a positive case, then we would use U07.2 plus Z20.8, which is contact with or exposure to other communicable diseases. And we can capture their respiratory manifestations as well. Patients who've had contact with a confirmed case or a suspected case, similar codes. If they have no other etiology described but they require hospitalisation, then we use the U07.2 for suspected COVID-19, but where there's no laboratory confirmation, and we code their symptoms. COVID-19 documented without any further information about whether testing was done. Can we ask everybody please to put themselves on mute? Thank you. Again, U07.2 suspected but not laboratory confirmed, and the symptom codes. And again, we can use those optional codes for isolation and laboratory testing if we decide that those are important things to also capture. Some patients come to the hospital, they have an acute respiratory illness, they might be suspected of having COVID-19, but further testing says it has been ruled out. If that's the case at the hospital level, we would code the infection that it's determined they have, but we would add another code, Z03.8, for observation for a suspected condition. And that basically describes why they've been admitted to the hospital, because we thought they had COVID-19, but in fact they ended up not having it. And some people, because COVID-19 is such a concern to everybody, some people actually refer themselves, and because they're concerned that they have COVID-19. Some of them will actually end up having COVID-19 as a diagnosis, and some will turn out not to have any condition. So for those particular patients, we would code Z71.1, person who had a feared complaint, but for whom a formal diagnosis wasn't made. And some patients might require a test for SARS-CoV-2 virus, even though they don't meet the strict case definitions that we've described earlier. So they might be undergoing a special screening just to make sure they don't have COVID-19. And in that case, in the hospital situation, we can use a Z11.5, a special screening examination code to capture information about what happens to those patients. So I think I'm happy to look at the chat now and see if there are questions that I can answer. And I see there's quite a lot of them. Or perhaps we should go on to Lauren's presentation first and then come back to the questions, because perhaps some of the things that she presents are going to answer some of the questions we've got. So are you happy with that, Dr. Eric? Is that okay with you?
Yeah, we're taking note of the chat. Yeah, please go ahead. Thank you.
Okay.
I think we'll
so,
have a discussion at the end. Thank you.
Thank you. Okay, Lauren, I'll stop sharing and I'll let you share.
Okay, thanks, Sue. Hi, everyone. My name's Lauren Moran. I head up the cause of death section at the Australian Bureau of Statistics. And really for the next bit, just wanted to take you through some of the certificates that we've seen in Australia. So we've had a bit over 900 deaths now from COVID-19. So there's been a lot of discussion around certification. Certainly the deaths at home has been an issue, probably for a very small amount of deaths here. But still, when people have those multiple comorbidities and working out that terminal chain to death has been a big query. And we do have two channels, I guess, for deaths in Australia. So most COVID-19 deaths have been certified by a doctor, but we have had a proportion that go to the coroner here. And in some way that does open up some opportunity for post-mortem and really being able to identify that terminal cause. But in a lot of cases, families reject an autopsy for a whole range of reasons. And then the pathologist and the certifying doctor are left with very similar questions, I feel, to what you raised earlier, is how are they going to actually work out what that chain of events is? And so I'll take you through some examples of death certificates that we've seen here. And so some of them are ones that I would consider really clear certification and that our team don't have to stress too much over. It's very obvious that it's a COVID-19 death, but then there's others where they're quite ambiguous and we have a lot of questions from our end, and just talking through some of those. And I've got a couple of examples also of where COVID-19 is a contributing factor, and we've found it quite useful with the way that it's certified to understand why. So I'll just play this from the start. And I'll just go over a couple of certification things because I found it really quite useful to look at the profile of COVID-19 in Fiji. So you understand where I'm coming from and the different things that we use to consider how we should best be capturing COVID-19 in our statistics and feeding that back to the health department. Here are the things that we're seeing. So we're also seeing much older age groups more likely to die from COVID-19. People aged over 80 in Australia are the most common age group to suffer that mortality and have quite a high case fatality ratio, especially when you hit that 90-year-old age group. And we find that most deaths in Australia really follow that traditional trajectory that's known with COVID-19, where the lung really is the most commonly affected organ and the most commonly affected terminal condition. So you can see with our deaths that over 50% had pneumonia as that terminal condition, respiratory failure, but we also see quite a lot of infections. So sepsis is also very, very common, and quite a few secondary bacterial infections as well that have come off that viral infection in the first place, which is quite interesting. And the renal complications, which was considered to be much rarer last year, but we're seeing more and more around the world. And we've seen those in around 5% of our cases at acute kidney injury now. And of course, the comorbidities, we also know that most people have a comorbidity on the certificate, at least one, generally lots and lots. And this can make it very, very difficult to work out if they were on that palliative pathway anyway because of some of those conditions that were manifesting, or if COVID-19 really did come in and affect that pathway to death. But we have dementia is by far our most common comorbidity in Australia. This is partly because we've seen a lot of nursing home residents contract COVID-19 and die, and dementia is a very common reason to be in a nursing home. But diabetes, chronic heart conditions, COPD and emphysema, hypertension, cancer, we're seeing those come through quite often as well, and especially those blood and lymph cancers. But I just wanted to recap as well on some of these certification guidelines. Sorry, let me just minimize that. There we go. So I just wanted to highlight that it is really, really important on the certificate to put in that causal pathway to death. Not only does it really help identify what could be the underlying cause, because by understanding that terminal condition, if it is pneumonia, it increases the likelihood that it was COVID-19 and maybe not one of the heart conditions that led to death. But because it's still such a new disease and we're hearing more and more about different types of complications that arise from COVID-19, it's really good to understand that pathway to death. And as it's been expanding around the world, we learn more and more, and what goes on the certificate really helps us understand that. Oh, there we go. And the chronic conditions and the comorbidities also really important to add on in that proper sequencing. So some of the things that we've already gone through, but also if there's some coexisting infectious diseases such as influenza or dengue, it would be really important to put that on the certificate as well. If somebody's recently had a surgery or some type of medical procedure that could have exacerbated events, also really important to get those onto the certificate. And it's just helping to bring together that story around COVID-19. So I'll just go straight into the examples now. So here's an example. This is quite a common type of certificate we would see here. And we can see that there's a very clear pathway to death. It's the acute respiratory distress syndrome, pneumonia, COVID-19. It's very clearly sequenced, and the comorbidities are put in part 2. And so something like this, it's very obvious to us that this should be counted as a COVID-19 death, and it's sequenced out, even with the intervals in it, which makes it much easier. Then we also have started to see a few more certificates like this, where, so with the acute kidney injury, we can see that they've got the proteinuria, and that's come from the COVID-19. So once again, really stepping out that the conditions in line 1A and 1B were caused by the COVID-19. And it certainly makes our job at understanding what's been going on much, much clearer. And once again, those comorbidities have been put in part 2. And just another example, so I'm just showing different ones with the different terminal conditions where we've been able to follow them really quite clearly, but also to show just that this information has been really useful for us. So we can see that this person has sepsis, they've had the hypoactive delirium, and COVID-19 leading that train of events. And in the part 2, we've got the Alzheimer's and the amyloidosis, and of course they've got the bypass graft. And things like the delirium has been a really frequent presentation for people with dementia and some of those neurological conditions. And sometimes the delirium is actually diagnosed as a symptom before the COVID-19 and some of the lung conditions. So it's been really helpful for us to understand that. But once again, sequencing it out, this is the certificate that our team was able to interpret really very easily. But of course, I understand that not everything is as straightforward. So these are ones now where the certification is perhaps a bit more ambiguous for us, where we have the terminal condition in part 1 being sepsis, and the doctor has said that the sepsis has come from the diabetes, but they've had COVID-19 as well. And for most of our certificates, we just tend to have the words COVID-19 there, so we don't have that it's lab confirmed or it's a positive test. But this raises a lot of questions for us when we're trying to work out, do we consider this a death directly due to COVID-19, or is this where COVID-19 is a contributing factor? So the coding rules that Sue just took us through would say that it is a contributing factor, but we know that sepsis is quite a common outcome of COVID-19. So without that chain of events really spelt out, we're a little bit unsure on whether COVID-19 should actually go in there. And that can lead to some differences that the statistical unit and the health information unit will have with the health surveillance teams. So being able to align that is really important. So for this one, if the doctor felt it was definitely due to the diabetes, this would help us make a much clearer decision. So if sepsis is still obviously the terminal condition, that's what's been diagnosed, but locating the source of that sepsis makes it clearer. So being able to get that onto the certificate, and then the COVID can stay in part 2. So this is one that we see very frequently in Australia and has brought up a lot of questions. And so we're seeing those typical lung conditions as the terminal event in part 1. So it's the pneumonia, the respiratory failure, and then the dementia. But very, very similarly to the previous certificate, we know that the lung conditions are very commonly due to COVID-19. And so it looks a little odd to us when we're trying to interpret, do we put that down as dementia mortality, or is it actually a COVID-19 death where the COVID-19 should have been up in part 1 there? So trying to avoid some of this ambiguous certification is helpful for us. And so what we're finding we're doing is we're doing a lot of backtracking. So we're trying to go back to doctors, we're having a look at other sources, and if it's gone to the coroner, we're very much going through that medical notes, and even if there hasn't been an autopsy, just reading that medical process to see, was COVID actually the cause of the pneumonia, or was it something else? And just another very, very similar one. And because we have seen quite a few people with diabetes, this type of thing is also fairly common, where we're seeing that the intervals are just not quite what we would expect. So they've got the kidney failure, they've got the chronic kidney disease, and the COVID-19. But the years and weeks are confusing. So as people in the health surveillance units and the statistical units, we're not really wanting to rearrange what the doctor has said, because we really have asked doctors for their best medical opinion. But this is really quite ambiguous and difficult. But it's also really, really important that we do count the COVID-19, which obviously you feel the same, as Ravi really outlined some of the challenges earlier that you're seeing on your end. But this can, if we avoid this type of certification, it can help. So we've ended up putting some in various spots. So some have gone to COVID mortality, some have gone to contributing mortality in Australia, just depending on some of those follow-up investigations that we had to do. So I just wanted to show you some of the pathology comments as well that have come through in Australia. And this is for when we have decided that it's a death directly due to COVID-19. And some of these comments and statements have really helped us understand that terminal chain and whether we would count it as a COVID death or just a person who's died with COVID. So you can see here that this is from the pathologist, that they're showing that there's widespread pneumonia, there's collections of the neutrophils, there's pulmonary emboli are confirmed. We're also just seeing general things, so just post-mortem scans. So even for a few of the patients where they had died and there was no autopsy, they still just did that scan of the lungs. And if there was an increased marking in the lungs, or even just simple comments such as a CT scan showing changes in the lungs, that really helped manipulate some of the decisions that we were making around those terminal conditions. And of course the alveolar damage in all lobes of the lungs was something that we really looked out for on some of these pathology comments, because they were things that really helped us with the decision making. And the lung ones are definitely a bit easier than the acute kidney injury ones, where some of those things are a little bit more difficult to interpret. So I wanted to show you as well just a couple of examples where the doctor had decided that this was a death of someone dying with COVID-19 rather than opposed to from COVID-19. And these were things that were really very clear for us to see that train of events and to put this as a non-COVID-19 death. So this is a lung cancer death. We can see that there's multiple metastases, and then it's actually been the metastases that's had the hemorrhagic transformation leading to death. So that one was really quite clear and a really good example that we've been able to put up to show that this one is obvious to us that this person was on a palliative pathway. And we've seen that with a couple of our cancer deaths. And this is one that we see a lot as well in Australia, and definitely because of those older age groups dying from COVID-19. So we're seeing a lot of mechanical falls. Of course, the neck of femur fracture is our most common injury at death with the mechanical falls. They've had a procedure, so this person has had the internal fixation. We see a few different types of procedures, but for this one, the doctor felt that it was really the prolonged immobility. And you can see that we even got the information here that the fall had led to the surgery, and then the person had started that functional decline leading to death. But then they had actually obtained that COVID-19, contracted it in hospital. So this was really helpful for us to understand where the infection came from as well. And they've also put those other chronic conditions there that contributed to that. But the falls have been very, very interesting because we've seen that they've gone both ways. So some doctors have felt that the person was recovering very, very well from their surgery with the falls. And we do have quite a lot of them here. But when they contracted COVID-19, they've then contracted pneumonia or some other condition from that, which has led to death. And doctors have felt that in some instances, the surgery would have been successful had it not been for that COVID-19 contraction. And for those ones, we've counted those as a COVID-19 death. But for this one, and there's a few other ones that are very similar. We've got some where there's a cervical spinal fracture, and they felt that the chances of recovery from the surgery were very, very low anyway. And for those, we've put those to a fall. And so here's a few comments where the pathologist has let us know that they really didn't think it was a death from COVID-19. It was just somebody dying with COVID-19. So there's comments such as there was no evidence of pneumonia or other changes to the respiratory system that would be expected in such a presentation. There was some evidence of changes to the lungs, but the change was not florid as seen in other similar cases. And when they say in other similar cases, they really meant as similar cases where the person had presented with COVID-19 and the changes to the lungs were really quite severe. And this one we see a little bit as well, that the patient was on a palliative pathway with the multiple terminal stage comorbidities while they were COVID-19 positive. This was thought to be an association rather than a direct contributor to death. So the pathologist is making comments such as these, which is just helping some of those decisions. And it sounds like with some of the panel discussions you're doing, it's a very similar process, and it sounds great that that's going on. And just before finishing, I just wanted to go through two certificates where we've seen people who have died from post-COVID-19 conditions. And Sue mentioned earlier that there's a lot of confusion, I guess, as to what a post-COVID-19 condition might look like when a person has recovered from COVID. And we've seen quite a few in those parts where there's definitely some ambiguity, especially when sometimes we're seeing neurological conditions such as meningitis, where there's been quite a few reports in places like the UK, but the link isn't made very clearly that it is from the COVID-19. But so these are two certificates where the doctor has really clearly highlighted to us that this person has a condition from that COVID-19 infection, and they wouldn't have had that condition had they not had the COVID-19. And I just thought these were nice examples to highlight. So this person's died from respiratory failure from pulmonary fibrosis, which they got from a COVID-19 infection. So the doctor was very clear about that. And then they put that they had recovered from COVID-19. So we've seen that in a couple of cases, and here's another one where they sequenced it out quite nicely for us. So they had the autoimmune encephalitis, and then it's highlighted that they did recover from COVID-19, but it's in that due to condition. It's sequenced out very nicely, and they've still put that lymphoma in part 2, which is still really useful information for us. So just before going to any discussions, I just wanted to highlight that the information collected is really, really important for informing health policy. And I can definitely sympathise with some of the difficulties with trying to decide if this is a direct COVID-19 death or just a contributing one. But that terminal pathway is really, really important in helping to determine that cause of death, and as are the comorbidities, and trying to link them to the terminal pathway, but also just for some of that health policy and prevention. But add in all of the extra information, and that clear sequencing is also really, really helpful, I think, at both the medical side and then when we get to the data side as well. But that's all from me. I did have a certificate from Fiji, but I just, before sharing it, I would just wanted to be very careful that people were quite comfortable with that, because it is a Fijian certificate, I guess, and not one that I own. So I'm happy to put it on the screen, but also happy to discuss anything as well before that. So I'll hand back over to you, Dr. Eric.
So thank you, Lauren, for that, and Sue. We're now open to discussions, questions. Maybe we'll start with the chat questions, and if anyone wishes to ask question via audio means, can you please raise your hand? Thank you. But I think thank you for presenting on the DCs from the certificates from Australia, but acknowledge that we also there is some Fiji certificates, and unless anyone objects, I think we can discuss it if it's okay with the team. But I think it's a good time to answer some of those questions from chat while people are raising their hands. Thank you. So Sue and Lauren, can we just respond to some of the chat questions, please?
So I'm just going through the chat at the moment, and it looks like everybody is providing their email addresses, and I haven't yet seen any questions, unless I'm missing something.
Maybe
Oh,
I'll
wait a
start
minute.
off by, yeah.
Oh, I've just found one. So there's a question in the hospital, all death certificates are issued after a birth certificate is acquired. That's not actually a question. That's a comment from Ravi. So I'm not sure. It sounds like if you've got somebody in a hospital who doesn't have a birth certificate, you're going to issue a birth certificate and then issue a death certificate. Is that what that's all about?
Sorry,
It's
just
Ravi.
interjecting, chiming in there. Sorry about that. It was a comment made by what Dr. Eric had said, the discrepancy in the names. So in the hospital, we have a system where we have to get a birth certificate, and the death certificate is based on the names that is on the birth certificate or
Okay.
a valid ID. Thank you.
Thank you for that.
Yes, I recognize the practice is done well at CWM and the divisional hospitals. It's just some of the peripheral facilities just need to get on to their practice, but I understand it's difficult at the moment, but it's an issue by law that we need to identify the person correctly. And we've had several, incidents before. But it's important. I think the important point is to identify the person correctly, either using a birth certificate or other means of identity. But definitely CWM has a process in place for with birth certificates and ensuring that the correct persons are receiving it. Those who pick up these certificates. Thank you. Dr. Ravi and Dr. Lucia, you have any further questions while the others are thinking of this? Oh, there's one there.
Dr. Eric, if I may just make a comment, I'm wondering, is there a linkage from a clinical governance point of view? We often have problems tracing patients' medical records. It's not uncommon for the same patient to have 3 or 4 different folders because they present using different names. Does that cause any problems from a coding point of view? And then for clearing the records officially of a patient who is deceased?
I imagine it would cause some problems for coding at the hospital level. I'm not certain that it would cause problems for the death certification and mortality coding unless there was a relevant past history of a condition which you should have put on the death certificate, which hasn't been put on the certificate because that information was not available. It's a little bit hard to answer the question though, but it certainly sounds like I'm a health information manager, and so my role is typically, if I was working somewhere other than a university, would be working in a hospital managing those medical records. And we have processes in Australia to try and identify patients who might use multiple names. And I would hope that eventually that sort of process would be introduced in Fiji if it's not used everywhere at the moment.
Thanks, Sue, for your comment.
Any other questions, please, by colleagues listening in? I just want to add that we also have an SOP that is currently being reviewed, and it basically looks at the process, the steps from, and it uses that process of how the information comes down. But it hasn't included, it was developed last year, it hasn't included these panels that Dr. Ravi has introduced, where a group of consultants have some discussion on this. It would be good to have further information from Dr. Ravi, whether we could just add it in this current SOP for certification of deaths for COVID-19. Thank you.
Sorry, Dr. Eric, there's a post from Dr. Nadim.
So Dr.
Yes, please
Nadim
go
has
ahead.
asked a question. To issue the death certificate, the member of the deceased should present birth certificate. Some of them don't have a birth certificate. Is it possible to bring another identification if the deceased to issue the death certificate? So I'm not able to answer that, and I hope somebody from Fiji can.
Yeah, I think we have other folks. Yeah. Dr.
Sorry,
Ravi?
yeah, any valid ID, Dr. Nadim, any valid ID, but we prefer the birth certificate. Thank you.
Dr. Eric, I'll just comment. And now that we've got the tablets that are used for vaccination, I'm sure they can search for the birth certificate number there.
Yes, thank you, Dr. Luisa. I think everyone might have, those who have access to those vaccination data. Now, every single Fijian that's vaccinated has linkage to the BRN number, and that's the number on the birth certificates. Thank you. There's also other sources that are linked to birth certificates, like what Dr. Ravi has mentioned. But I think the key point again is ensuring that we identify the disease. Now, Fiji, it's, everyone here knows that even in both major ethnicities, we have multiple similar names for similar family names, even in one community.
May I ask a question? The discussions that you have, your panel discussions to determine causes of death for COVID-19 cases, at the end of those discussions, are you completing the death certificate?
Yes, so the main intention of that that is to get a classification for the death certificate. And in that process, we also go through the clinical management and highlight. So it's been a twofold thing.
That's great. Thank you. I see there's another comment. When a national health number is made, records often just take verbal information. They need to strengthen proper identification checks. And yes, I think that's a very important comment.
That is a very important comment, and I think this is the area that Sue is referring to. The national ID, unique ID number, Digital Fiji is turning it out for the vaccination ID numbers, and that's to my understanding. And we are trying to add it into the Tamanu laboratory testing with the swabbing that now is operational. And so once we get this national unique ID number that's under the digital transformation unit of government, they are actually churning out these numbers, we'll sort out our NHM. Because as correctly said by Dr. Ranu, it doesn't require any ID for you to register within the NHM, within the PETIS Plus. Thank you.
I have to say, if there's any positive side to COVID-19, it's encouraging a lot of improvements in health information collection and reporting.
So any other comments, colleagues? Well, I guess there's no other questions. I can't see any other questions. With my fellow colleagues, oh, there's a message. Yes. it all comes to the unique national ID. So I think the principle of the unique national ID number is to put all those numbers into one, even your TIN, your other numbers in, just have one number for everything. And like I said, there's this government, there's a group of government, there's a group that actually working on this, but they are trying to add this into we are waiting this to add into our vaccination database to have this national unique ID number. And as Dr. Luisa has mentioned, once that is done, then it's digitally possible to actually try and correct this with our NHM. And the issues are forthcoming. I'd like to also raise an issue for the clinicians that we are having a number of people in the central division. I mean, ordinary persons in public, like relatives of deceased, coming to headquarters requesting copies of the death certificate. And we understand it's for monetary purposes or other legal reasons, but the only reason is that the Ministry of Justice the main reason is not accepting the death certificate by doctors, especially if it does not have an official stamp on it. So according to the BDM office of the Ministry of Justice, they want a doctor's stamp to confirm that it's a genuine certificate. I know we haven't discussed this in this forum, but it's an important issue that's bringing 30+ people on a weekly basis to headquarters to actual copies or to verify the certificates they have received. So I'm just urging the doctors, please ensure that if you're signing any certificates, have it stamped by, have an official stamp on it. And that's important for people because we don't want them moving around they keep going back and forth from BDM to Ministry of Health headquarters, sometimes trying to access CWM for this. Just one simple thing, having a stamp on a medical certificate. Thank you. Anyone want to add any further comments before I close this session? Got 1 minute going. Okay, I think we are generally done. I'd like to now thank you, the participants, for being part of this webinar. I want to thank especially Sue and Lauren for taking the time to join us in this training and be our major facilitators of this training. I also acknowledge our senior colleagues, Dr. Luisa, Dr. Ravi, and the people working in the background from IMT who've provided the data, as well as Liz, Dr. Alipati, not forgetting our other friends that are in the divisions who have contributed. We thank you all for coming in this afternoon, and I hope you have a wonderful weekend. It's nice and sunny now, possibly in Suva, but in the west. I thank you all. Thank you, Sue and Laura. We'll close this session, and we look forward to the participation in future trainings. To our SPCL colleagues, thank you for coming on board. Thank you very much.
Thank you,
Thanks,
everybody.
everyone. We're coming on a Saturday as well.
Yeah.
Thank you, Dr. Eric.
Thanks, Dr. Eric. Bye.
Nimode.
Bye.
Bye.